Thank you. I'll start, sir. Good evening, doctors. Welcome to this webinar on role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993, 30 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. Hetero with 21,000 employees globally, and Hetero Healthcare is the largest closely held pharmaceutical company in India and is amongst the largest manufacturers of ARV, APIs and FDFs in the world. Hetero Healthcare has Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. With Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020 they received an award of Pharma Excellence for COVID drugs. Today's webinar role of oseltamivir in flu management, we have got Dr. Pallab Chatterjee sir to guide us. Dr. Pallab Chatterjee, welcome. Dr. Pallab Chatterjee is MBBS DCH, MD Pediatrics, DNB Pediatrics FIP, Diploma in Pediatric Sleep Medicine, Colorado University, European Diplomate of Pediatric Respiratory Medicine, Chairperson Computer and Medical Informatics Chapter of IIP 2123, Secretary of West Bengal Academy of Pediatrics 2018 to 19, Member of Advisory Committee of Vaccination and Immunization Practices of IIP 2018-19, Member of Executive Committee of IIP in 2020, Sir was Scientific Chairperson of West Bengal Chapter of Pediatric Pulmonology and one of the founder members of National Respiratory Chapter of Pediatric Pulmonology. Dr. Pallab has authored chapters in various textbooks like PG Textbook of Pediatrics, UG Textbook of Pediatrics, IIP Textbook of Pediatrics, IIP Textbook of Tropical Pediatrics, IIP NRC Textbook of Pediatric Pulmonology, IIP Standard Treatment Guidelines, IIP Guideline of Immunization in 2018 and 2019. This brief introduction, I once again extend a warm welcome to Dr. Pallab Chatterjee and hand over the session to him. Over to you, sir. I stop sharing. Yes, sir.
Thank you, Dr. Prashant. Thank you for the introduction, and thank you, Hetero, for this opportunity to be here in front of you. And I think we will start sharing.
Yes, sir.
Okay, so is it visible now,
Yes,
my
sir. Yes,
slide?
sir. Clearly, clearly.
Okay. So, thank you. Today's session, like we were supposed to do along with Dr. Subhashish Roy, but unfortunately, due to some other problems, emergency problems that has crept up, he could not attend. So, we'll be discussing today on the empiric use of oseltamivir in flu management. And as you all know, that this session is brought by Hetero Healthcare. Now, the point that we are going to discuss today is like about healthcare challenges in monsoon and their diagnosis. We are going to discuss about the influenza and its complications, the clinical evidences of oseltamivir, and guidelines regarding the empiric use of oseltamivir. That is something that we are going to discuss today. That when you should use oseltamivir without definite documentation of flu. So with this, we start off with a case. This is a child, a 4-month-old male child who presented with cold and cough for 4 days, high-grade fever, difficulty in breathing, and there was a history of contact in the maid who had severe cold and cough. So this is one of the classical, typical cases that we usually see in our clinical day-to-day practice. A typical case of viral respiratory illness in a young child. On examination, this child was sick looking. There was nasal clear discharge. There was a harsh cough. Throat was congested. There was tachypnea. There were recessions. Conducted sounds were there, and fine crackles and bronchi, and otherwise, other systems were all within normal limits. So, looking at this history and typical examination, what is the usual diagnosis that we all think of in such a young child? Well, we the first thing that comes to our mind is acute bronchiolitis when you have a child an infant with the first episode of cold and cough who presents with fever, coryza, there is a history in the family, and usually they come in clusters, and there'll be no other atypical features other than the fever and the nasal discharge. Management is just symptomatic. It hasn't changed over the years. So there's because it's the bronchioles that are involved, nothing much really works other than symptomatic management and oxygen. And you can grade bronchiolitis according to how they behave, whether it's mild, moderate, or severe. So if the child is able to feed well, if the child has very minimal respiratory distress, if the saturations are well above 93, then you consider this as a mild case. A severe case would be when they are very sick, they are reluctant to feed or unable to feed, there's severe respiratory distress with lot of chest retractions, and the saturations are low, may not be correctable with oxygen. You might need to put in a high flow nasal cannula and oxygen. So anything of that sort would be severe, and anything in between the two would be a moderate. So upper respiratory infections in children, they average around 6 to 8 episodes in a year, and there could be around 60 to 112 days in a annually where the child might be sick with cold and cough. And usually these episodes they last for 10 to 14 days, and the cough usually lasts for around 2 to 3 weeks. So that is a post-viral cough that lasts for around 4 to 3 weeks. So usually we get the history that the mother comes and tells us that initially the child had fever, the fever responded, but the cough is persisting. So that is a typical history that we get, and that is how the upper respiratory infections behave. And majority of the cases, you do not need to do any investigations in such in these children. However, in our index case, we had done a blood test which had shown a CRP which was mildly elevated. We had done an initial chest X-ray and which was grossly normal. Now the issue is that what was the need for doing an X-ray and what was the need for doing a blood investigation? If the child is not behaving like a bronchiolitis, if there is something that is out of the way, the child is very sick, the child is needing a lot of oxygen or some support or high flow nasal cannula oxygen. So there you start thinking that whether we are dealing with something which might be more sinister. So these were the X-rays, the repeated X-rays that were done, and you could see that gradually the child is becoming worse and the X-rays are deteriorating. So depending on that, we did a biofire test of the upper respiratory secretions, and what we got is a positivity for influenza A. Now, influenza A, the investigation of choice is biofire, and there you get within an hour or two you get the reports. So you get all the usual viruses, a few of these bacterias, and atypicals can also be got with this test. So there are various tests that are done. PCR tests are done locally, but biofire is the one which is accepted worldwide. And remember that flu is a notifiable disease. This is from Park and Park, and you can see that flu is one of the diseases that is notifiable. And we also had a article in the local newspaper saying that be on guard against the swine flu vaccine virus and why it is so important. So when we talk about these illnesses, you have the influenza-like illness, the ILI, the H1N1, the SARS and the COVID-19, and the number of cases in our country is increasing over the years. So we have quite a few cases where you have these H1N1 infection, the influenza A infection, and deaths as a result of that. And this is a bar diagram which shows that the cases of influenza infection that has increased over a period of time from 2015 to 2019, and so have the deaths that have increased over a period of time. So it is increasing alarmingly in our country. So when we talk about influenza, we have the various viruses. One is the influenza A, which causes frequent epidemics due to minor antigen variation. And when there is a major antigenic variation, where then you get periodic pandemics. So it could be either shifts or drifts, and there you can have the major pandemics or other minor variations leading to frequent epidemics. Influenza B, very common nowadays. We are getting a lot of influenza B infections in our part of the country. And I'm sure you must also be seeing a lot of such influenza B virus infections. It causes local epidemics. It doesn't like become a pandemic sort of thing, and it infects only humans. And influenza C virus, again, it infects humans and swines, and it generally causes a very mild respiratory illness, and they usually do not cause a lot of epidemics. So, what we are really worried about is influenza A. That is the one that causes a lot of problems. Influenza B can become very serious and sick, and but they are usually localized to small areas. So currently circulating ones that we see are the H1N1 and the H3N2. So what happens is people with flu can spread it to others around even up to 6 feet away. And flu viruses can are spread by droplets when the patients with flu, they cough, they sneeze, or they talk, and they can land up in the mouth or the nose of the people who are close by, and they can be inhaled into the lungs. So basically, if you have to prevent yourself from flu, then you need to wear a mask if you are close to a person who's affected, or you try to stay away from the affected person, not to send patients to school if they are sick, and to stay at home. Even for adults, try to stay at home and away from people so that it doesn't spread. Wash your hands with soap and water very frequently, as we were always doing during COVID times. And we must always remember that even before the person is sick, a day before the person is sick, the person starts spreading the infection, and they spread it up to a week after becoming sick. And children may pass the virus for even longer, more than a week. So that is something that we need to take into consideration. So if you differentiate between the influenza like illnesses, the H1N1, the severe acute respiratory infections, and the COVID, basically they all are very, very similar. It's very difficult to differentiate between them clinically. But the for COVID, the loss of smell and the loss of taste is something very important. And other than that, all of them, grossly, there is not much of a difference between the various infections. So if what are the red flag signs? So if you have these children who have fast breathing, or they have trouble in breathing, they have cyanosis, they are not feeding well, they are very lethargic, not interacting well, or on also they are extremely irritable, they don't want to be held, and there is a rash along with this. So all these things are red flag signs that we need to take care of. So any infant who is not able to breathe, who is not able to eat, who is dehydrated, and these are patients who need to be taken care of immediately. In case of adults, again, if there is a CNS manifestation like sudden dizziness or confusion, there is a lot of vomiting, severe vomiting or dehydration, difficulty in breathing, and then these are things that we need to be careful about. So the complications, there can be a severe acute respiratory infections. There can be pneumonias, bronchitis. There can be acute otitis media. There can be worsening of underlying diseases like asthma and COPD. There can be even acute respiratory distress syndrome, and ultimately death. So, the treatment is largely supportive, and it consists of bed rest, increased fluid consumption. You might need some cough suppressants when the cough is very harassing. You need to give antipyretics and analgesics like paracetamol, and non-steroidal anti-inflammatory drugs for fever and myalgia. Most patients with influenza, they will recover in 3 to 4 days. However, the malaise can persist for weeks, and severe cases might need intravenous hydration and other supportive measures. So we will come to the categories A, B, and C later. And what are the drugs that are available? So neuraminidase inhibitors are the ones that are used commonly. So of these drugs are active against both influenza A as well as influenza B. And the adamantins that were there previously are not used that much. They are active only against influenza A. Of the neuraminidase inhibitors, we have the oseltamivir and the zanamivir. The zanamivir is the one that is given by inhaled method. So the problem with that is you have to be like a little bit older to take that inhaled medication. It is taken like a rotahaler, and there is a chance of exacerbation of asthma and cough in such a patient. So you have a patient who is an asthmatic, develops a influenza infection, and then you give the medicine which can worsen the disease. So that is why zanamivir is not used much. So the drug that we are left with is oseltamivir. And oseltamivir is a potent selective inhibitor of the neuraminidase enzyme of the influenza virus A as well as B. It is basically a prodrug. It is converted into the active form in the liver, and it inhibits the influenza virus replication and pathogenicity and prevents spread of infection. So what happens is the virus is stuck there on the cells and it does not spread. So it is effective against all strains. So what happens is this neuroamidase is this enzyme which cleaves the receptors which contains the salicylic acid, and thereby it releases the viruses into the tissues, and thereby it starts multiplying. So in the airways the virus is stuck to the host cell, and this enzyme cleaves the receptor and it is then released into the airways, and it continues to start multiply and spread. What happens is when you block this enzyme, then it cannot cleave, so the virus sticks to the cell and it halts the viral replication. It does not spread, so it prevents the release of these viruses, and thereby it limits the infection spreading within the respiratory tract. This was one of the first neuraminidase inhibitor that was approved, and it is now available in more than 100 countries. So the dosage in adults for treatment, it is 75 milligram capsule that is available. It is given twice a day. And in chemoprophylaxis, it is once a day. So nowadays we do not use chemoprophylaxis. If it is required, we give 75 milligram capsule twice a day for 5 days in adults. In children, it varies according to the weight. So 2 weeks to 1 year. So it is safe in very, very young infants. 2 weeks to 1 year, you give syrup 3 milligram per kg twice daily, and thereafter it is according to the weight. So above 10 kgs, less than 15 kgs, is 60 milligram twice daily, then 90 milligrams per day divided twice daily, 120 milligram per day divided twice daily, and in adults and any child more than 40 kgs, it is 75 milligram twice daily. So that is the about the dosage. Now, what are the basic idea of today was to discuss about the empiric and the early use. So, what happened was this was a prospective trial where antibiotic usage was seen from 3,564 subjects, a huge age range, right from 13 to 97 years, who were affected with the ILI and enrolled in 10 placebo-controlled double-blind trials of oseltamivir. And what was found that in patients with influenza, oseltamivir infection will reduce the usage of antibiotics. It will reduce the incidence of hospitalization, and it will also reduce the resulting lower respiratory tract infections. So again, another retrospective medical chart review of 442 patients Median time from symptoms to oseltamivir administration was around 5 days. And the subjects were divided into two groups based on the time of admission. So whether it was less than 2 days, 3 to 7 days, 8 to 14 days, and more than 14 days. What was found that earlier you give oseltamivir, the symptom reduction will be much better. So it is supposed to be administered as soon as possible. So before you actually know what is the disease, if the child is very sick, and if there is a influenza epidemic that is going on in the community, then you start oseltamivir, initiate the treatment of oseltamivir as soon as possible. It shortens the hospitalization and it reduces the severity of pneumonia. However, if it is given even later, it did show considerable potential for reducing pneumonia. So, even if it is administered after 48 hours of symptom onset, it does show a lot of potential in reducing the pneumonia and the infection. So, what are the guidelines? They suggest that empiric treatment is recommended. Treatment should be started as soon as possible. Lab confirmation of the influenza virus is not essential for the starting of the treatment because the later you start, the worse will be the results. The negative lab test for H1N1 does not exclude the diagnosis. Therefore, if there is a epidemic of H1N1 going on and you test for H1N1, it comes negative, child is sick, you can still continue 5 days of oseltamivir because you might not be getting H1N1 every time you do the nasopharyngeal swab. And in high risk infants exposed to a child with a patient with influenza, you consider presumptive treatment with oseltamivir. Empiric antimicrobials are given to treat all likely pathogens, and empiric antibiotic treatment is based on the clinical diagnosis. So it includes a treatment, oseltamivir, if there is some sort of a exposure to influenza, there is a local epidemic going on, there is a exposure to a place where there is a history of influenza going on, and the patient is has been admitted with viral infection or pneumonia, you start treating with oseltamivir. So, recommended that anti-influenza treatment should be prescribed for all patients with community-acquired pneumonia who test positive for influenza. So, that is a very strong recommendation, and there is good evidence for that. Now, certain observational studies also suggest that treatment with oseltamivir is associated with a reduced risk of death in patients who have been tested for influenza positive as well as hospitalized for community acquired pneumonia. So, if it is a community acquired pneumonia and you have been tested for oseltamivir, it is better to start the treatment within 2 days of symptom onset or hospitalization because that is going to give the best outcome. Although if it is missed, the first 48 hours is missed, you can still start treatment up to 5 days of symptom onset because it has been found that it reduces the risk of death in patients who have been hospitalized with community acquired pneumonia and tested positive for influenza virus. So with this, we come to our next case. This is a 2-year-old child with fever for 3 days, with chills, dry cough, gradually increasing with time. There is sore throat, there is conjunctival congestion, body ache, vomiting. There is mild tachypnea, harsh vesicular breath sounds. The child was started on comoxiclav. There was some cough syrup was given. The situation remained the same. 2 days later, the father was admitted with high fever, fatigue, severe cough, and was tested as influenza B. Now, what do we do? So, once we discuss this, when we have a child who's exposed to somebody who is admitted with influenza or has been tested positive for influenza, we have three possibilities whether it is a confirmed case, whether it is a probable case, or whether it is a suspected case. So, a suspected case is a person with an acute febrile illness with the onset within 7 days of a close contact with a person who's confirmed case. So, here in this patient, we have not confirmed it, but is in contact with a person who is a confirmed case. Within 7 days of travel to a community where there are one or more confirmed cases of influenza, or resides in a community where there are one or more confirmed cases. So, such a patient will become a suspected case. And if a patient with a acute febrile illness who is positive for influenza but not type for influenza H1 or H3 or whatever by RT-PCR, and is positive for influenza by the rapid antigen test there, and it meets the criteria for suspected case, then you consider these patients as a suspected case of influenza. And and also, if this individual is with a clinically compatible illness who died of an unexplained acute respiratory illness, is considered to be epidemiologically related or linked to a probable or a confirmed case. So therefore you consider these patients. And what is a confirmed case is a person with an acute febrile illness with lab confirmed viral infection at one of the WHO approved laboratories. So, what are the tests that we do to confirm a case? Is a real time PCR, a viral culture, or a fourfold rise in influenza virus specific neutralizing antibodies. So, if these are there, then this is a confirmed case. So, these are the three things that we need to remember when we are discussing in an influenza pandemic. And the categories, so you have the category A, B, and C. So category A is a patient with a mild fever, mild cough, mild sore throat. There is no body ache, there is no headache, there is no vomiting. So it is only symptomatic. You do not need to give oseltamivir. If along with this the patient has a very high grade fever, severe sore throat, or if there are risk factors, then you consider them as category B. You do the RT-PCR, you isolate them at home, and you give oseltamivir. And when along with this, the child is even sicker, breathless, chest pain, drowsiness, there is hypotension, there is sputum mixed with blood, there is cyanosis. Here, these patients will need hospitalization and will definitely need oseltamivir. So, as we've discussed this, there are two groups of drugs, and who should take these antiviral medications. So, if they are hospitalized with flu, if they are very sick with flu but have not been hospitalized, or who are at increased risk of various a serious flu, depending on their age, so extremes of age or underlying health conditions. Example, you have patients with severe asthma or chronic lung disease or diabetes or heart disease. So they are patients who are very much at risk and should start taking the antiviral medications. Pregnant women, if they are affected with flu, should always be considered as high risk and to be started with antiviral treatment. So, with this, we come to the third case. This is a 2.5-year-old child with fever, with chills and body aches for 2 days. There was severe cough the next day with sore throat, breathlessness, and not taking anything orally. The child was admitted in the hospital. Other members were all okay. The child was started with the usual treatment of IV fluids. Oxygen was given salbutamol and ipratropium nebulization, and comoxiclav was started. There was no improvement in this child. So this was the X-ray of this child, quite sick, and the child was tested and was found again to be influenza B positive. So oseltamivir was added. The fever and the cough came down. The antibiotics were withdrawn because we knew that this child was suffering from influenza B. 2 days later, again, the child had very high fever with chills, with tachypnea. The bronchial breath sound was heard in the infraclavicular region. And now you can see this child who was quite toxic, and there was a huge pneumonia that had developed the right upper lobe pneumonia. Clindamycin was added, ceftriaxone was started, the child gradually improved, and the child was discharged home. So always remember that post influenza, you can have MRSA, which is extremely common, and the drug of choice would either be, you add Vanco, Clinda, or linezolid and fluoxetine along with these drugs. So, to sum up, proper diagnosis can and early treatment can prevent flu complications. there is a definite role of empiric use of oseltamivir, which is available by the trade name of Fluvir by Hetero Healthcare. It reduces the lower respiratory tract complications, reduces the incidence of hospitalization and antibiotic use, and all the societies, the WHO, the American Thoracic Society, the Ministry of Health and Family Welfare of Government of India, they all recommend empiric use of oseltamivir for treatment of influenza A as well as B. Thank you very much for your patience.
Thank you, sir. Sir, when you use oseltamivir, have you, I mean, do you generally use it after investigation or use it as a first line? I mean, without
Uh,
investigation, without the lab test.
Both, basically both. When we have a very sick child who's admitted to the hospital,
Okay.
particularly if a child is admitted with a pneumonia or no, there's an epidemic of flu going on, and the child is extremely sick, we usually start with oseltamivir even before testing.
Before
But
test.
in the OPD, we usually do not do that. We do not start off immediately unless we have a definite history of contact with flu with some family member who's got flu or something. Otherwise, we usually do not start. We wait, and if the child doesn't seem to be improving, we do the test and we start oseltamivir.
Generally, by the time a child is brought to the pediatrician, the 3 4 days have already happened. First, the child may go
Yes.
to a GP. I mean, the GP may treat in his own way and then refer probably, or maybe the patient
Hmm.
would wait at home. This little lapse in time or little what else could be very critical in terms of response, I suppose.
Absolutely, absolutely. So if the child is sick, really sick, then there is no question of waiting. We
Exactly.
really start.
Should
But if
be,
the child is stable, then
yeah,
you can actually, test and see, and
absolutely.
you can start. Yeah.
But
And
the
if there
best,
are no other risk factors, because if the child is supposing is not an asthmatic or is not does not have any other risk factors like a chronic heart disease, a chronic lung disease, chronic renal disease, all these are not there, then you can really wait and see. Otherwise, it's always better to start and then stop later if you find
yeah,
that it is not there. Yeah.
the best thing is to seek medical attention as early as possible and not
As
take
early as
home
possible.
treatment.
Correct,
Yes,
correct.
maybe
Yes,
GP,
yes.
maybe consultant, whatever.
Absolutely.
Yeah, and have you seen any adverse effect with oseltamivir?
The only thing that happens sometimes is a little bit of nausea and vomiting.
Okay.
So many patients have this problem. Many kids have this problem of nausea and vomiting with oseltamivir. Otherwise, usually it's extremely well tolerated and nothing significant
That
happens.
is significant. And
Mm.
the syrup, is it accepted by
Yes,
pediatrician?
yes, 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 yes. Definitely. There's no question about
Accept.
acceptance. That is quite fine. So that is okay. But sometimes they have this nausea after taking oseltamivir.
And I mean, sometimes the GPs may start I mean, the generally the preference is for start antibiotics as compared to
Yes.
antivirals.
Yes, yes, yes,
Yeah.
yes. So that is the issue. We need to actually understand that, yeah, if there is a typical history, if there are multi-system involvement, there is conjunctivitis, there is eye discharge, nasal discharge, cough, there is maybe some loose stools, then start thinking of virus before
Viral.
thinking of bacteria. So that
Generally,
is very important.
I suppose I may be wrong. Bacterial infection generally affects one system, and by viral infection generally
Yes.
affects multiple
Yes,
health.
exactly, exactly. So it will be multi-system involvement and it will be multi-people involvement. So you'll be
Multiple.
multiple people in the family who will be involved. The bacterial infection is usually one. So it is one system and usually one person in the family who is
Correct,
affected.
correct, correct. Right, doctor. Thank you so much for your insights. I mean, these practical insights will definitely help the doctors more than the published papers and the guidelines. And I'm sure the doctors will benefit out of your interaction. And thanks, doctor, for taking time to attend this webinar. Thanks, marketing sales team of Hetero. Thanks, IT team for your IT supports. Thank you so much, sir. Wish you a very pleasant evening, sir. You can sign off. It was indeed a pleasure to be with you again. And wishing you a happy 2026.
Thank you, thank you, thank you. Hope we'll meet again before
Yes,
2026.
yes, yes, yes. Nothing like that. Huh? Bye.
Thank you, thank you, thank you very much. Good night. Good night.